Hi everyone. We'll make a start. I'm not going to give a long preamble for the workshop, but I do want to thank everybody for joining us for this important workshop, and also thank Unitaid, without whose funding the workshop wouldn't be possible. Particular thanks as well to international colleagues that have joined us in this beautiful venue in Liverpool. We've got an exciting day. We're going to discuss two underserved patient groups, paediatrics and maternal, both representing all of our futures. So with that, we'll crack on, and I'll introduce Ethel Weld, who's joining us from Hopkins. She's going to chair the first session. Thanks, Ethel.
Good morning, all. Thank you so much for joining. It's my delight and honor to chair this session on long-acting therapeutics in maternal health, and my privilege to introduce our first speaker, Professor Sharon Nachman. Professor Nachman is the chief of the Division of Pediatric Infectious Diseases at Stony Brook Children's Hospital. She's also the Associate Dean for Research at the Renaissance School of Medicine at Stony Brook and directs the Office of Clinical Trials at the institution. And she's served as the PI and chair of the IMPACT Network, where she's developed and directed the maternal and child HIV and TB clinical research agendas for the past 10 years. And in this capacity, she's developed and led dozens of clinical trials that have led to licensing of new therapies for children and pregnant women with HIV and TB, and helping decrease the morbidity and mortality that they suffer. Her advocacy for children with HIV and TB has been nothing short of ferocious, which is most needed exactly now. Without further ado, Sharon Nachman.
Good morning, everyone. This is Sharon Nachman. I'm calling in from Israel. Today I'm talking about priorities for research in pregnant, postpartum, and lactating women. This is as close as I can get to Liverpool, and I'm sorry I'm not there with all of you. So today what we're going to cover is PregLac, a little bit of history, their current status and plans, some of the other maternal pediatric networks, including IMPRINT, the Maternal Fetal Medicine Unit, the Neonatal Research Unit, the Global Network for Women's and Children's Health, as well as some other networks. I have no conflict of interest. I am the PI and chair of the IMPACT Network. So to start off, as everyone here knows, we have an ethical obligation for inclusion of pregnant women into our studies. These are snapshots of just a few of the studies that talk about including pregnant women as well as children. I'm sure many here in the audience can talk about many others, but the bottom line is always the same. Excluding pregnant women does not help anyone at all. Although approximately 60% of pregnant and lactating women take one or more prescription medications for pre-existing or pregnancy-induced conditions, approximately 90% of clinically approved medications actually don't have any drug labeling information for them. And the issue facing us today is how can we fix this? And more importantly, where do long-acting medications fit in? Well, let's start with NICHD. NICHD is heavily invested to research to address maternal morbidity and mortality in the US. In addition to its broad and robust maternal health research portfolio, NICHD engages in partnerships, both across NIH as well as with other groups, to guide clinical recommendations that providers need to deliver care. Thus, they formed PregLac. PregLac was formed in 2016 via the 21st Century Cares Act and was led by NICHD with representation from multiple sectors. The committee developed a report to Congress in 2018 and an implementation plan in 2020 before its charter unfortunately expired in 2021. The PregLac Implementation Working Group was then established in 2023 as a Consolidated Appropriations Act and reports to NACHD Council. The working group's objectives are to review publicly available materials pertaining to implementation progress, invite speakers from relevant agencies, some of which I will reference today, or non-federal entities to discuss progress on this implementation plan. And I will show you what the plan looked like. They have to report their findings to the National Advisory Child Health and Human Development Council, and ultimately a report to Congress must be developed. The 21st Century Cure Act established the PREGLAC, which is the Task Force on Research Specific to Pregnant Women and Lactating Women, to advise the Secretary of the U.S. Department of Health and Human Services regarding gaps in knowledge and research on safe and effective therapies for pregnant women as well as lactating women. The task force work culminated in a set of recommendations, and they were gleaned during 4 open meetings and a public comment period, which I was fortunate enough to attend. The central theme of these recommendations was really basic. It was the need to alter cultural assumptions that have significantly limited scientific knowledge of therapeutic product safety, effectiveness, and dosing for pregnant and lactating women. The overall goal in PRELAC as of 2018 was to increase the quantity, quality, and timeliness of research involving therapeutic products used by pregnant women, develop a proactive approach to study development and study design, develop a systematic plan for collection of data, including safety data, optimize pregnant registries, expand the use of drug-based pregnancy registries, similar to that we see in the HIV registry for pregnant women, facilitate access to data and transparency of information in these registries, as well as several other things, including a plan to design a health record systems to link the mother and infant records, something that really we've talked about for a very long time. They also wanted to leverage large studies and databases, some of which we'll discuss this morning. The recommendations also included to include and integrate pregnant women and lactating women in clinical research agendas for everyone, increase the quality and quantity of all the things we do, and interestingly, create a public awareness campaign to engage the public and healthcare providers in research. So it shouldn't just be the scientists talking about it, but the community as well. What are the other recommendations? They wanted to reduce liability. We often hear that when we work with our pharma partners, that they're scared of liability, and that's why pregnant women are not enrolled. The plan was to facilitate an evidence base for these products so that liability would be decreased. They also wanted to develop special programs to study specific therapeutic products using the National Institute of Health's Best Pharmaceuticals for Children Act, or BPCA, as a model. And that's how we were able to study drugs in children. And they wanted also to develop programs to drive discovery and development of therapeutics as well, not to have it in phase 4, but to start in phase 1, targeting pregnant women. They wanted to implement a proactive approach to study design, and they wanted all of this to happen before 2019. Unfortunately, as we're sitting here, we recognize that almost none of this has in fact happened. In addition, there was a lot of discussion regarding pregnancy postpartum requirements, and I've taken this from FDA 21 CFR item 3112.32a, and you can please look that up. And that pregnancy safety studies can be required under Section 505 of the FD&C Act, that the lack of a safety signal in non-clinical reproductive toxicity data does not indicate that a drug is safe to use in pregnancy, something we know. And that lack of human pregnancy safety data is really, in essence, a safety issue. That congenital malformations due to drug exposure in pregnancy are serious adverse events. However, historically, pregnancy registries have been issued as post-marketing requirements, and these post-marketing requirements actually never enroll sufficient women in them to say anything about safety of that drug. This is a slide that I've taken looking at the number of PMRs issued from 2007 to 2020. And you can recognize that in pregnancy, we have far more than in lactation, and there are existing disease-based pregnancy registries rather than PMR in certain therapeutic areas. So this does not include antiretrovirals, antileptics, and psychiatry drugs. Post-approval pregnancy studies, there's guidance for industry that was established in 2019. I've put the link in below that you can take a look at this, But the most important thing is that while this was written in 2019, we are here in 2025, and it continues to be in draft format. It has never been codified or approved, and it is non-binding. The purpose of it was to provide sponsors and investigators with recommendations how to design investigations in pregnant women exposed to drugs. However, there is still no guidance with regard to those ideas. The recommendations in the FDA proposal were suggested to develop pregnancy registry. We know these take a long time to complete and have a huge selection bias. It's always the people that say, I had an outcome that was horrible, that go and upload information to a registry. There's also something called database studies. This requires mother-infant linkages. And as many of you know here, the mother delivers at one hospital, the baby, if not well, gets moved to another hospital, gets a different medical record, and there's no link between what the mommy took and what the baby is doing. Often covariates are not captured, like smoking, obesity, alcohol, as well as other comorbid conditions. And then there are pregnancy surveillance studies, such as rare disease registry. Data from those suggests that the numbers are too small to say anything about them. There are broad categories for the plan. They included therapeutic products for pregnancy indication, lactation indication, non-pregnancy indication, looking at the patient, the patent, what's doing, any supplements, but this plan has still not been enacted. Subpart B of the Common Rule Regulations notes that if research holds out the prospect of direct benefit to the pregnant women, the prospect of a direct benefit to both the pregnant women and the fetus, or no prospect of benefit to the women nor the fetus, when the risk to the fetus is not greater than minimal, and the purpose of the research is development of important biomedical knowledge that cannot be obtained by other means, her consent is obtained. However, and this is very important for all of us sitting in the room, if the research holds out the prospect of direct benefit solely to the fetus, then the consent of the pregnant women as well as the father is important to be obtained. As you can imagine, we often deal with populations that the father is not available, may not be interested in approving it, a consent, or doesn't want to be bothered. And that often puts a barrier into our ability to get that woman on study. Summary of the July 2024 meeting, but a year ago, says Congress has not authorized any new programs specifically focused on therapeutics in response to PREG-LAC recommendations. And now NICHD is focusing on leveraging existing programs for the study of existing medications using existing approaches to prioritizing research. There are 5 overarching themes that emerge from the July 24 meeting. These include distinguishing between pregnancy and lactation. These are really 2 different items and should not be just considered as one item. Assigning clear ownership over a recommendation. Who gets to say what the recommendation should say? Engaging multiple diverse stakeholders, requiring additional resources and congressional action, as well as continuing assessment of implementation progress. Unfortunately, we are not meeting most of these goals. They also looked at increasing expertise in obstetric lactation research, increasing participation of pregnant women and lactating women in clinical research by developing community advisory boards, prioritizing data collection specific to the products that are often used by pregnant women, not to go after the drug that's very rare to be used, but the ones that are commonly used. Increase the quantity and the quality of basic science, PK/PD, pharmacoepidemiologies, and randomized control trials. Increase the availability of clinically meaningful information about these therapies. Increase the number of products with adequate and useful information. Augment the dissemination of current accurate information on these therapeutic products. Don't look at something that was published 15 years ago. Look what's been published now. And keep pushing this collaboration among stakeholders. And this meeting today is the kind of meeting that will help get the stakeholders talking to each other. This is a schema of the PREG-LAC recommendations in pregnancy. I apologize for the very small font, but I want to draw your attention to the color. Green means it's working. Red means it's really not working. And yellow kind of means in the middle. So if you look at how much green is on this screen, you can recognize that for the most part, all of the things that PREG-LAC said it wanted it to do have actually not moved forward at all. There's more specific review by the therapeutic area in the 2024 recommendations. And they focused on very specific items, saying these are sort of the hot targets that we have to hit. These include low milk supply, nutritional hyperemesis vomiting, nutrition, mental health, hypertensive disorders, cardiovascular, preterm birth, infectious diseases, including HIV prevention and treatment, hepatitis C treatment and syphilis treatment, substance abuse and exposure, and perhaps some others not mentioned here in case something hot pops up. Think about long COVID. What are some of the examples now of some of the NIH clinical research networks? They include the IMPRINT network, the PTN network, the obstetric fetal pharmacology research units, the maternal fetal medicine networks, MFMU, and of course, IMPACT. The downside is the challenges in obstetrical trials. Eligible patients are often uncommon, and screening and enrollment are expensive. And there's a need to balance between efficacy and safety, as well as clinically relevant outcomes and long-term follow-up. How long do you need to follow the baby before you say they're safe? All of these factors, of course, drive up cost and uncertainty. And the return on investment is unfortunately quite small for drug companies due to the short duration of treatment, limited number of patients who they perceive will use the medication, making a large-scale funding uncommon or very rare. Let's look at some of the networks now. The IMPRINT network is the Maternal and Pediatric Precision and Therapeutics Network. This is a snapshot from their website. IMPRINT is a national resource to improve maternal and pediatric pharmacology research outcomes by providing support at every step of the research project. It includes outreach support, includes custom support with pharmacometric analysis, and includes best practice protocols, as well as a knowledge base and real-world evidence core. The IMPRINT knowledge base collects, integrates, and curates maternal and pediatric pharmacology research. There's a gold knowledge base as well as a silver knowledge base here. Data Modeling, Knowledge, and Resource Coordination Center is part of IMPRINT. And this Data and Model Knowledge and Research Coordinating Center is jointly housed at Indiana University and Ohio State. Together, they're supporting, coordinating, and expanding the maternal and pediatric therapeutic research. We at the IMPACT Network are very happy to be sharing a lot of knowledge with our IMPRINT colleagues, and currently are cross-talking on at least several protocols that are rolling out to sites. This is their knowledge base, their real-world evidence, the collective online perinatal and pediatric repository called COPPER, and pharmacometric data and clinical trial design is also available. Let's move now to the Pediatric Trials Network, or PTN. The PTN is studying the formulation, dosing, and efficacy safety of drugs that are currently licensed. They're using the Best Pharmaceuticals for Children Act, or BPCA, as their ability to enroll children on studies. Results at a glance are some of the PTN network studies that have actually gotten data from licensed drugs in children. But you're going to say, that's very nice about children. What about pregnant women? So for pregnant women, they have a study called CUDDLE. This is the pharmacokinetics and safety of commonly used drugs in lactating women and breastfed infants. So they're, while not looking at pregnancy, they're looking postpartum. And this study has now studied 10 off-patent drugs, including ciprofloxacin, doxy, levo, amoxil, as well as other medications. And this is a snapshot of the CUDDLE data that is available on the PTN website. What about the Maternal Fetal Medicine Unit Network? There are multiple sites across the country in the US, and they include a clinical center, a data coordinating center, and the Funding Institute. And as you can see from these little hatches all over the map, 26% of the papers that the network produces are cited in medical guidance, meaning they are of a high impact. They have included something called the New Mama 2B Heart Study. This enrolled more than 6,000 women who gave up their time looking for links between pregnancy problems and future disease. Understanding this will help find better ways to predict, prevent, and treat heart, brain, and other diseases. They have diverse backgrounds and experiences. and they are currently enrolled and looking to do further studies from their data. This NHLBI study was established in 2013. It currently has over 6,000 participants, and its major findings are women, for example, with APOs are at higher risk for hypertension as early as 2 to 7 years after delivery, that there's a significant association of maternal obesity with APOs and cardiovascular health, and that APOs are more likely a marker of pre-pregnancy cardiovascular disease risk, and that there's a vital role of pre-pregnancy health for optimal pregnancy and postpartum outcomes. What about impact? Well, impact, our mission is to improve health outcomes in infancy, childhood, adolescence, pregnancy, and postpartum among those who are impacted with or living with HIV, as well as evaluating novel treatments and interventions for HIV, TB, and other related complications. And we are a global collaboration of investigators. We were formed in 2006, and we are currently funded for the next several years. I hope this is still true a couple of months from now. Some of the maternal impact studies that I'd like to just mention briefly include PROMISE, which studied 4 different sub-studies looking at treatments to prevent infection from mommies to babies. 1026 was an opportunistic study like 2026 with multiple arms that studied each drug that was given to pregnant women, as well as postpartum safety to mommies and babies, to see what the safety and PK of those drugs were. 2009 studied PrEP in pregnancy. 2010 looked at 3 different antiretroviral regimens to treat HIV. 1078 looked at use of INH during pregnancy among women who were latent TB positive. And 2050 will look at long-acting cabo plus rilpivirine in pregnancy. One study not referenced here, called 2041, will be studying how to treat hepatitis C during pregnancy. All of these studies are now moving out into the field, and we hope to get data from them in the next year to 2 years. What about some examples of large databases? Well, there's the Medical Expenditure Panel Survey, which includes data on health services costs and how services are paid. There's the Healthcare Cost and Utilization Project, which provides data on hospital stays, emergency room, and other visits. There's the Pregnancy Risk Assessment Monitoring System, which collects data on maternal attitudes and experiences before, during, and after pregnancy. And there's the Maternity Practices on Infant Nutrition and Care, which collects data on breastfeeding practices from maternity care service facilities. These projects are all available for us to look at data to help plan our next studies. DASH is the Data and Specimen Hub funded by NICHD. The link is here. And there are specimens available which include amniotic fluid, blood, breast milk, Buffy codes, environmental samples, red blood cells, hair, etc. And it is a centralized resource for researchers to share de-identified data from studies which were funded by NICHD. It serves as a portal for requesting these biospecimens, and it aims to accelerate scientific findings to ultimately improve human health. What about drug labeling? And I thought I'd spend just 1 or 2 minutes on that. Drug labeling information for pregnant and lactating women has changed over the past few years as FDA has been implementing the pregnancy and lactation labeling rule. It removes the letter categories A, B, C, D, and X, and now the reason it removed those is they were found to be oversimplistic and misinterpreted as a grading system. The FDA has replaced these categories with an integrated risk summary and provides better details, including an assessment of the known risks, consideration of medical disease factors, animal data put in context of human exposure, human data when it is available, and it explicitly states when no data is available. So where do we go next? What are the things we need to do? Well, we need to study medications in pregnancy by trimester. We have to work on better modeling. We have to keep pushing to stop excluding women who are pregnant from studies. We have to start thinking about long-acting medications, not just for HIV. We have to think globally, listen to the community, and ask what is it that they want, not what is it that we want. And remember, women are themselves individuals and not just the carriers of future patients. So thank you to everyone who has listened, the individuals and families who are engaged in clinical research, and let's continue to move the science forward.
Thank you, Sharon. I think we'll move on to the next presentation and save questions for the end, if that makes sense. I'm delighted to introduce Dr. Rachel Scott. Dr. Scott is an associate professor of obstetrics and gynecology at Georgetown University in Washington, D.C. She is the scientific director of women's health research for MedStar Health Research Institute and the associate chair for research for the Women's and Infant Services Department of MedStar Washington Hospital Center, where she is a practicing obstetrician gynecologist. Dr. Scott's passion for women's health and commitment to underserved women drives both her clinical career and her commitment to clinical and translational research. She currently divides her time between clinical care and research, primarily focused on HIV and HIV prevention in women. And she's the protocol chair of the Impact Network study of long-acting cabotegravir and rilpivirine in pregnant and postpartum women. Her enormous energy, talents, and devotion to her craft are truly inspiring, and I'm exceedingly proud to call her my colleague and dear friend, Dr. Scott.
Good morning. Thank you for the introduction, Ethel, and thank you for the invitation to be here. I am honored. As Ethel mentioned, I am an obstetrician, and I'd like to take the moment to point out that I'm not a clinical pharmacologist or pharmacometrician, and I'm actually a rather jet-lagged obstetrician at the moment. So I hope that I can count on you to be a forgiving and kind audience. The topic that I was asked to speak about was pharmacokinetics and safety considerations for long-acting therapeutics, and I'll specifically be speaking about HIV and HIV prevention during pregnancy and breastfeeding. These are my disclosures, and given that the topic at hand is pregnancy and breastfeeding, the population of interest is women and other individuals assigned female at birth, who I will be referring to as women for simplicity. I also want to acknowledge that much of this presentation will be a review for this audience, but I'm hopeful that this will serve as both a jumping off point for this afternoon's breakout sessions and also to level set, so we're all coming from the same place. The learning objective as such is to review the W questions, what, where, when, why, regarding the pharmacokinetics and safety of long-acting therapeutics for prevention and treatment of HIV in pregnancy and breastfeeding. Moving on to where and to the global perspective, women and girls comprise more than half of the almost 40 million individuals with HIV around the globe. And this heat map from 2021 demonstrates the proportional burden of HIV among women worldwide, with the lion's share being in sub-Saharan Africa. In several countries, up to 90% of reported cases are among women and girls, and this is compared to 20 to 40% in most of Europe and the Americas. Since 2019, HIV/AIDS has been the leading cause of death for women among reproductive age around the world. Yet despite the long-standing pervasiveness and gravity of the epidemic, women, and in particular women of reproductive age and during pregnancy, have been either systematically excluded or underrepresented from HIV prevention and treatment research. The implication of this is a delay of a median 6 years between when drugs are typically approved and when we have PK data in pregnancy, and this is frankly clinically dangerous. In the setting of a clinical trial, we are able to assess a drug among a relatively small number of participants in a controlled setting with close follow-up to assess the safety and outcomes of both maternal and fetal/neonatal participants. In the absence or delay of clinical trial data, these above risks are magnified as women and their medical providers are making medical decisions about clinical management without evidence and without the controlled setting of a clinical trial. There's the risks of choosing older and ineffective or even harmful medications, and there's also the risk of disease harm from undertreatment. In response to this delay and historical exclusion, in 2020, an international task force of researchers and community advocates called for an end to the evidence gap for pregnant women around HIV. The task force specifically called for the inclusion of pregnant women in research as a means to achieve equitable protection from drug-related risks and to access first-line medications, as well as equitable respect for pregnant women's own health, not just the health of their fetus. And this is really critical, especially in the HIV field, given that in the early years, research involving pregnant women attended centrally to pregnant women as a vector of HIV transmission, rather than a person worthy of care in and of herself. The who and when for this talk should be relatively obvious, given the title and what I've talked about thus far, but why we single out this who is because of the unique physiologic changes of pregnancy. This slide depicts the shifts in pregnancy relevant to oral drugs, broken up by absorption, volume of distribution, metabolism, and clearance. And I don't have the time to go into each of these individually, but what I want to point out is the changes, or differences rather, in terms of the physiologic shifts in pregnancy relative to long-acting therapeutics. The concerns about nausea and vomiting in pregnancy are no longer relevant, nor are first-pass effects. And although changes of absorption may still be relevant for injectable formulations associated with changes in fat distributions, but this is still to be evaluated. Additionally, concerns about changes in inhibition or induction of gut enzymes are no longer relevant. But this is not the case for hepatic enzymes, and this is actually particularly relevant for drugs such as cabotegravir and rilpivirine, where increased hepatic induction leads to lower exposure in the second and third trimesters. And when we think about drug exposure in pregnancy, it's important to consider pregnancy stage and what's transpiring physiologically. Starting with preconception or periconception, for individuals who do not desire pregnancy, drug-drug interactions with contraception is particularly important, as this can impair the effectiveness of contraception. And pre and periconception, thinking about potential teratogenicity, is relevant through up to approximately 8 to 10 weeks in the first trimester, when organogenesis is complete. Moving into the first trimester, we also need to think about the impact of and on maternal nausea and vomiting. In the second and third trimesters, dosing is highly relevant, and this is when the physiologic changes of pregnancy are at their peak. For example, the increased volume of distribution, increased hepatic induction, increased GFR, and increased clearance. And we also need to think about the drug impact on fetal growth. Peri-delivery, we need to think about pregnancy and maternal outcomes and the impact on the newborn as well. And in breastfeeding, you always have to keep in mind the degree and the effects of the exposure of the infant to the drug of interest. In women living with HIV, there's a potential concern for maternal viral transfer in women who are not virally suppressed, and associated late risk of transmissions, as well as infant drug resistance. Moving on to why long-acting therapeutics in pregnancy and breastfeeding. Long-acting retrovirals have the potential to significantly and sustainably improve prevention and treatment outcomes for individuals with increased exposure to HIV or living with HIV, especially during pregnancy. Current regimens offer between monthly and every 6-month alternatives to daily or even twice daily ART or PrEP. And long-acting therapeutics obviate the barriers of pill burden, of daily adherence, of stigma related to disclosure of HIV or taking an HIV prevention drug. Pill burden is particularly notable in the first and early second trimesters, when nausea and vomiting of pregnancy can complicate tolerance of oral medications. Viral suppression and optimization of adherence is critical for maternal health and prevention of maternal HIV in the case of PrEP, or prevention or optimization, again, of maternal health and perinatal transmission in the case of treatment. As well as, this is also critically important in the postpartum period, where adherence and retention and care is known to drop off. And it's critically important to maintain maternal health in this period as well. Of note, adolescents and adults of reproductive potential are already using these long-acting therapeutics, and either intentionally or unintentionally, many of them are becoming pregnant. These long-acting therapeutics that are on board are present systemically with systemic exposure in pregnancy, intended or not, and with a long washout period for many of them. And those are all, it really calls for research in long-actings in pregnancy. There are currently 3 FDA-approved long-acting injectable options. The first 2 are cab and rilpivirine. Cabotegravir is an integrase strand inhibitor. It can be used solo as for HIV prevention, PrEP, administered every 2 months after an initial loading dose followed by a 1-month follow-up dose. Or it can be used in combination with rilpivirine, which is a non-nucleoside transcriptase inhibitor, administered either monthly or every 4 weeks, really, or every 2 months after that same initial and follow-up dose 1 month later. Lenacapavir is the newest kid on the block. It is a capsid inhibitor that was approved for prevention only last month and has been around for treatment for several years now. It's administered sub-Q every 6 months, although of note, lenacapavir for treatment is only indicated in cases of multi-class drug resistance. I ran out of W's, but research to date for these 3 drugs will now be reviewed. Initial PK and safety data in pregnancy were limited to phase 2 and 3 clinical trial data among individuals who were on cabotegravir for treatment of HIV prior to a diagnosis of pregnancy. Unfortunately, in these trials, these individuals were switched to an alternative oral regimen upon recognition of pregnancy. We do have PK data for 7 individuals, all of whom remained virologically suppressed throughout the postpartum period, and whose tail concentrations for both cab and rilpivirine remained within the observed range for non-pregnant individuals. There's safety data for an additional 18 patients, all of which is considered to be consistent with background data. There was 1 case of infant ptosis that was not considered to be associated with study drug. Much of what we know about CAB outside of that study, or outside of those studies, I should say, is in the context of HIV prevention, which is to say these are individuals without HIV, without those associated comorbidities, and without rilpivirine co-administration. HPTN 084 studied the effectiveness and safety of long-acting cabotegravir compared to daily oral tenofovir disoproxil fumarate and emtricitabine for HIV prevention among individuals assigned female at birth. Last July at AIDS 2024 in Munich, the HPTN 084 team presented both the safety and PK data for the open-label extension study, where upon diagnosis of pregnancy, pregnant individuals were given the choice of continuing their current regimen or switching to a regimen of their choosing. Starting with maternal outcomes, there was no observed increase in cesarean delivery or delivery complications with the CAB group. And you see there is a bump in the prior CAB group exposure, prior CAB exposure, but you'll recall from the prior slide that 91% of individuals in the active CAB group were also exposed to CAB prior to diagnosis of pregnancy and without a safety signal in that group. And this is also a composite measure. There was no one delivery complication of note. There were no maternal deaths, and perhaps most importantly for the 084 protocol, there were no maternal HIV infections in pregnancy. These are pregnancy outcomes with background rates shown in the boxes on the right. And although the rates of preterm birth and spontaneous abortion may seem high, they were all within the range of historical controls. Lastly, in terms of safety data, these are the infant outcomes. There were 4 deaths in the active CAB group, 1 associated with a major congenital anomaly that was not disclosed, and 3 due to respiratory distress. None were deemed associated with CAB exposure. And in case you're concerned that there seems higher in the active CAB group, I will draw your attention to the sample size of the active CAB group, which is 5 times the size of the other 2 groups. Within the open label extension, there was a nested PK study of 75 individuals. The PK data from the first 50 participants was also presented at IAS immediately following the safety data. All 50 were on CAB prior to pregnancy. And as you can see, the average troughs were largely maintained around the protocol-defined target of 4 times the PAIC90. The amount of PK data from this cohort is relatively scant. There's one trough measurement per trimester, leading to a firm rationale for more intensive, opportunistic, real-world PK work during pregnancy and postpartum. In terms of rilpivirine, most of the data we have is for the oral formulation. There are several studies for oral rilpivirine which shows decreases in exposure in the second and third trimester of between 20 to 50%. There's evidence of both transplacental transfer and transfer in breast and chest milk, although the numbers are relatively small. And in terms of real-world data, the APR has ruled out at least a twofold increase in birth defects associated with first trimester exposure. I will note that this decrease in 20 to 50% is associated with CYP3A4 induction, and no dose adjustment has been recommended by any guidelines committees at this time. Lastly, in terms of PK and safety data for CAB and rilpivirine, we have a case report of an individual who was on CAB and rilpivirine prior to pregnancy Q8-week dosing and remained on it during pregnancy, as well as a case series of 31 pregnancies of which we have we have safety and outcome data for 23. In terms of the case report, the CAB and rilpivirine concentrations were maintained above the PA-IC90, and the cord blood to maternal plasma ratios for CAB was 1.27, and for rilpivirine was 0.6, consistent with oral formulations. In terms of the case series with of pregnancy outcomes, they were divided in 3 groups. There were individuals who, can I use this as a pointer? Yes. No. Okay. Yes. Excellent. Can I control it is another story. So of individuals started on CAB prior to pregnancy, 4 were then switched to oral ART. All of them were virally suppressed at time of their first antenatal visit. At time of delivery, 2 out of 4 had an undetectable viral load, and the other 50% had a viral load less than 200. These are the medications that they switched to, and all neonates were HIV negative at time of delivery. An additional 13 participants continued on CAB and rilpivirine, either Q4-week or Q8-week dosing. 11 out of 13 were virally suppressed at their initial antenatal visit, and the other 2 had a viral load less than 200. At time of delivery, the numbers were similar. All but 1 had a viral load that was undetectable, and the last participant had a viral load less than 200, and again, all neonates were HIV negative at delivery. The last group were individuals who actually switched to CAB and rilpivirine during pregnancy at a median of 22 weeks gestation. There were 6 individuals in total. Only 1 of the 6 at their initial antenatal visit had a viral load that was undetectable. The remaining had viral loads of between approximately 600 to 111,000. At time of delivery, 5 out of 6 had an undetectable viral load, and the remaining 1 participant did have a viral load of 2,000, but had received CAB and rilpivirine only 2 weeks prior and was coming down from a viral load of greater than 100,000. The regimens that they switched from are listed here, and all neonates were HIV negative. Turning now to lenacapavir, Purpose 1, the data of which was also presented at IAS last year, was a phase 3 double-blind randomized controlled trial of adolescents and young women, in South Africa and Uganda. And participants were assigned to receive twice yearly subcutaneous len compared to FTAF or FTDF for HIV prevention. At the time of the interim analysis, there were 500 pregnancies among 487 women out of a total of more than 5,000 total participants, and the breakdown was relatively even per group, other than the FTDF arm, which was smaller in general. Pregnancy complications were relatively uncommon in this study, in this cohort. There were no observed differences per group and no signal of adverse pregnancy complications or birth outcomes with len. And as there were no seroconversions in the study overall, there were also none in pregnancy. So this slide summarizes what we do and what we do not know about long-acting therapeutics in pregnancy, and I will walk through it for you relatively quickly. A negative signal a negative sign indicates that we have no data. The positive sign indicates that we do have data, and all of it actually seems to support the use, or at least more research, in long-acting therapeutics in pregnancy. And question marks means that the data may exist or should exist if you refer to the protocols that are posted online, but the data have not yet been made public, either by presentation or by publication. So starting with cabotegravir, we obviously have continuation data from 084, but no switch data in terms of PK. There is placental data is limited to the one case report. There's no breast or chest milk transfer data, and safety and effectiveness is largely limited to the RCT for PrEP and only in terms of treatment, the case series. For rilpivirine, the numbers are smaller. In terms of PK, we're limited to a case report for continuation and nothing for switch. Placental transfer, as I mentioned previously, seems to be similar between the small amounts of data that we have, again, limited data in breast and chest milk. Very little data on safety and effectiveness in long-acting therapeutics. And for lenacapavir, we actually have next to nothing other than safety and effectiveness data, as it has not been made public. There is one treatment for individuals on len for treatment. There's only one case report, I should mention. So in response to these gaps and in preparation for clinical trials, several groups, including the Liverpool group and folks here, as well as the Impact 2040 group, also here, have presented or published models for cab and rilpivirine during pregnancy in the setting of treatment. I am unfortunately out of time, but I wanted to at least highlight this model, which was adapted by Rob Bees and Yifan Yu from a maternal fetal PBPK model by Dahlman et al. In order to predict concentrations of cab and rilpivirine in women switching switching to cab and rilpivirine mid-second trimester and continuing in their second and third trimester. Both the Liverpool model and this model do predict lower concentrations in pregnancy than in non-pregnant individuals, but still well above the 4 times the PAIC90. And you see the accumulation demonstrated in both of these graphics, both of which represent favorable predicted outcomes for long-acting in pregnancy. So in terms of what's next in research, as you may have heard from Sharon's talk, Impact 2040 has been laid to rest due to shifts in NIH policy and shifts in funding from industry, and in its place, 2050 has risen from the ashes to evaluate PK and safety for cab and rilpivirine in pregnancy. In this much trimmed down version, we are starting with Q4-week dosing only, and we do plan to additionally collect and eventually analyze cord blood, placental transfer, breast milk levels, and infant washout. In speaking with colleagues from industry, it's unlikely that more prospective research will be done in cab or rilpivirine in pregnancy. However, we anticipate that the PK data associated with both HPTN 084 open label extension and Purpose 1 will be modeled and published. We rely heavily on real world data such as the APR, and listed here are additionally several studies highlighted at the LEAP meeting of either new long-acting therapeutics, new combinations, or new dosing regimens. I'd like to thank the conference organizers, my 2050 team, and the colleagues from whom I have borrowed or stolen slides. I look forward to answering your questions at the end of this session.
Thank you, Rachel. Our next speaker is Dr. Adeniyi Olagunju. He is a senior lecturer in the Department of Biochemistry, Cell and Systems Biology, and a member of the Center of Excellence for Long-Acting Therapeutics, where ongoing cutting-edge innovative research is currently transforming drug delivery strategies for major disease burdens. He leads the perinatal pharmacology group within CELT, and research within the perinatal pharmacology group is focused on broadening our understanding of drug safety and efficacy during pregnancy and lactation. Dr. Olagunju's overall research program aims to transform the assessment of drug safety in pregnancy via generating pregnancy-relevant safety information early on in the development of life-saving therapeutics. Dr. Olagunju.
Thanks a lot for the very nice introduction, and I'm very glad to be on this group of speakers talking about this important subject, and thank you all for coming for this event. So I would like to start with this outline of some of the things that I want to cover. While there are so many technologies and innovations out there, I'll focus on two primary ones. The first one is injectable non-carrier systems in long-acting therapeutics. I'll discuss using some examples, some of those attributes, and then I'll move on to non-injectable implantable systems. And then finally, I'll touch a little bit on insulin in diabetes, as it's one of the major maternal health priorities, and then postpartum hemorrhage. So here is an image from a paper that is currently in preprint, which aims to summarize the classification systems that we use for technologies that enable long-acting therapeutics in general. And you can see broadly there are two, injectables and non-injectables. And then you can classify those further into carrier-enabled, non-carrier-enabled, implantable, and then non-implantable. This statement taken from the FDA guidance document on products, including therapeutics and biologics that may contain nanomaterials, makes a very important statement about what might be required when nanomaterials are integrated into the formulation of long-acting or other drug delivery system. And the key message there is if there is a potential of altering the biodistribution to certain organs, then it might be necessary to have some further safety assessment. And some of the organs highlighted there include our fetal brain and the placenta. So if there are nanomaterials in the composition, even apart from the main active pharmaceutical ingredient that would alter the biodistribution, then it might be necessary to carry out further assessment. And because of that, I'll try to stay away from good nanoparticles and other nanomaterials that are often used in some drug delivery systems, and focus instead on where we have a lot of experience with some products already in clinical use, and that is the injectable non-carrier-enabled systems. Among them, you notice there is the in situ forming implants or gel, the aqueous drug particle suspensions, oil depots, and so on. Quite a number of drugs, including cabotegravir and ripivirine, belong to this class of nanocarrier systems. And I would like to highlight some of the attributes. And the first one is the flip-flop kinetics, because for this group of technologies, it's a really key attribute that enable the long-acting delivery, but it also helps us to assess what we might expect during pregnancy and lactation. So this flip-flop kinetics, as we call it, basically means that instead of the absorption rate is much less than the elimination rate constant. And that means the overall pharmacokinetics is controlled by the absorption. So basically, it's impossible for the drug, for the baby that is in the womb or for the baby that is being breastfed to be exposed to the drug unless it is not released, unless it is released. So the drug stays at its site of depot injection and gradually gets released into the system. So it's only what is in the systemic circulation that will get to the placenta, and if the drug molecule is able to cross, that the baby is eventually exposed to. Same thing with breast milk. The drug wouldn't move into the breast milk unless it is released first into the systemic circulation. So this is a major attribute of this class of drug delivery systems. It also means that there is a long tail in the PK for this class of drug delivery systems. Remember that it's at the depot, and even if you discontinue the medication, at some point the depot is still there. And so the drug will still continue to be released. And this is the example of cabotegravir and ripivirine, which was presented by Shaquille at the last CROI. And just to draw your attention to the pregnancy period. So this is a scenario where someone gets pregnant, and right after pregnancy is discovered, they took only one additional injection. Pregnancy was discovered, and then they stopped. And you notice that both ripivirine and cabotegravir continue to be detectable in the system, even until delivery and even the postpartum period. And that's a really important attribute to have in mind for this class of therapeutics. And it really raises the question about the value of stopping the medication, that can you really stop it? Because if there is a switch, for instance, from the injectable to oral versions, we're basically adding more drugs on top of what is already in the system. So it's a key consideration to have in mind. And that's a summary of the demographics of the virtual population that was simulated. I'll still come back to this in a bit. Another component of the attribute to consider is the caution for repivoring, especially the initiation in pregnancy. In this paper that was published recently, we simulated both the monthly injection for repivoring and for cabotegravir. And you notice for repivoring, overall, if it is initiated during pregnancy, it really struggles to get above the efficacy threshold. But don't forget that this is not a steady state. This is initiating the therapy, because it takes a long time. It takes months to get to steady state. So it's important for technologies in this category to really take that into consideration when treatment is initiated in pregnancy. So just yesterday, I spoke with Shaquille. I asked him that, why don't you try and see what we get for continuation during pregnancy, using the exact same model that is used for termination of the treatment at steady state, to see what we're able to achieve. And the reason why I was interested in that was because from the data that was presented at CROI, it was very clear that 8 weeks after the treatment was discontinued, both repivoring and cabotegravir stayed above the efficacy threshold if the discontinuation happened at steady state. And here is what is interesting. You notice here that even for repivoring, where we think there might be problems because of the activation of CYP2A4, it actually seems from this model, which is still imperfect, it seems to stay above the efficacy threshold if the discontinuation happened after the drug has already achieved steady state. So these are some of the key attributes to have in mind. So there might be reasons to worry, especially if the treatment is initiated during pregnancy. But maybe for cabotegravir and repivoring, maybe we really have nothing to worry about if there is sufficient time to achieve a steady state. But of course, there is still need for more data in this area. Another drug that belongs to this class of technologies is LEN. I'm glad Rachel has covered a lot on this. And the question is, do we use it or not during pregnancy? Rachel has mentioned some of this, but what I want to draw attention to in the technology is that it comes as a solution, and when it's injected, then it seems to form a precipitate under the skin, and that creates the depot from which the drug is gradually released. So it still belongs to this class of medication. And all data from animal studies, developmental and reproductive toxicity studies, all of them appear to be positive for LEN. So that doesn't seem to be any reason for concern. So it could be really a game changer for HIV prevention and treatment, not just for the general population, but even for pregnant women. Now, here's a summary slide of some of the available technologies that are currently approved or in development. Those on the far right, those are the approved ones. The green is where we seem to have sufficient confidence that this can be used in pregnancy. The amber is the one where there are still some question marks. So where do you think you put CAB and repivoring? Now, here's what I think, that for CAB, it looks like all the data that we currently have, both in terms of safety and PK, they seem to point in the right direction. That seems to be nothing to worry about. For repivoring, there are still some question marks about whether the PK will be sufficient during pregnancy. But from the little modeling exercise that we've done, it depends on whether we're talking of it being started during pregnancy, or pregnancy comes in when it has already achieved a steady state. For LEN, we've seen some very promising data from what Rachel presented, but of course we still need to know more about the PK. Now move on now to the second class of technologies that I want to touch on, and this is non-injectable implantable systems in long-acting therapeutics or during pregnancy. This is an interesting technology. If you think about the example of ethnogestrel implant, just 4 centimeters, containing 68 milligrams of drug, highly efficient, just 0.1% failure rate. So a single implant, effective over a period of 3 years. Imagine if we could do that for infections. But of course, we know the loading capacity will be an issue because this is an hormonal therapy. But it does point to an area where there might be an opportunity to do something really unique. What is really unique about this type of technology is the ability to remove them. So they are removable, of course, with some incision being made, but it's a possibility that someone wants to terminate the treatment, then they can be taken out. So we can think of this in the context of a drug that we know definitely that it is not safe during pregnancy, and then somebody is taking it, they weren't planning to get pregnant, and then they get pregnant. So this could be a type of technology that could be useful for a population like that, and then it can be taken out to terminate the treatment. But is this really possible? I'll show you this paper published a couple of years ago. This is a study in non-human primate, carboxygraphil in situ forming implants. What is interesting about this is not a polymeric implant. It's actually biodegradable, but it's surprising that they were still able to retrieve it, even after some time. So the retrieval was done after so many different time intervals, 30 days, 60 days, 90 days, and so on. And what is interesting, the summary is that 11-fold decline in the plasma concentration of carboxygraphil was observed when the retrieval was done. So that's really good. But it was impossible to completely eliminate carboxygraphil. And that's understandable because remember, this is not really a polymeric system. It's an in situ forming implant. But it's really promising, and it shows that if it were to be a polymeric implant, maybe you can even achieve a much more quicker drop in drug concentration and retrieve it effectively. So that's why I like the potential value of this particular type of technology. But whether this will really have sufficient loading capacity to be used for HIV treatments, as an example, or for some other maternal health priorities still remains to be seen. Now move on next to diabetes. This is a major maternal health priorities. Actually, very important, gestational diabetes or diabetes that pre-exists even before pregnancy. In this paper here, I took a snapshot of the pregnancy categories using the old system for different insulin formulations. And you can notice that for almost all of them, it doesn't seem to have any issue when it comes to pregnancy. So they have really good classification for use during pregnancy, and they are often the treatment of choice for women during pregnancy. But I'd like to focus in particular on long-acting insulin. Remember, insulin, because of the very fast clearance, it has to be taken very frequently. So this structural analog of insulin has some structural modification that is shown there. But the key summary is that this prolongs the distribution of insulin in the system, and that leads to the possibility of taking it on a weekly basis instead of on a daily basis or even more frequently. And it also retains the efficacy of insulin for controlling blood or glucose level. And this is further explanation of the structural modification that was done, both to weaken the receptor affinity in order to delay or the elimination and to strengthen the thermodynamic stability and some other properties. But the key point is they were able to achieve ultra long acting, making it possible to administer just once every week and retain full potency when it was tested in humans. This is currently in use. It has found its way into so many different guidelines, including in this country. But insulin icodec is not the only one. There is also insulin F-Citora, which is also administered once weekly, a different type of structural modification. But it's all the same that the elimination is slowed down, and that enables less frequent injection. This is a summary of some of the phase 3 trials that led to the approval of both the icodec and the F-Citora. You can see the PK there as well as the PD. So it's quite very efficacious and is currently being in use. So here is a summary of what this means for long-acting insulin when you compare the daily insulin to the weekly one. So it helps to really minimize the daily peak and trough of the daily administered insulin. So the long-acting nature of the weekly insulin helps to stabilize our glucose control, just like we observe for normal small molecule therapeutics. So it's a really promising technology that has now found its way. And there are data coming out which now show very clearly that pregnancy outcomes, infant outcomes are really very good for this formulation. Next is lessons that we can learn about how to really implement a technology specifically for maternal health. And I've taken a case from postpartum hemorrhage, which is actually the largest contributor to maternal morbidity and mortality globally, 25%. So it is huge problem for women immediately after pregnancy mostly. And the standard therapy is oxytocin. It is used to prevent it, but there is a problem with real-world efficacy despite its effectiveness. And this is because of the issues around the heat instability. So it's stored in the clinic, it's administered, but it's no longer of any use at that time, in many cases with poor storage facilities. And that led to interest in actually developing a heat-stable analog of oxytocin. And this was achieved stable at room temperature, like you will find in many countries, 30 degrees for 36 months, even at very high relative humidity. And it was found to be non-inferior, which is really the interesting part when compared with oxytocin. And what was done, and this is what I really want to highlight on this slide, how this was achieved. The first step was to identify and evaluate the need. That what are the major maternal priorities? And it's always clear that postpartum hemorrhage was a major one. And they made a decision, okay, let's prioritize that as something that we need a solution to. And then they used a human-centered design in approaching the way the formulation and everything was done. So a lot of stakeholder engagement, patient groups, healthcare providers, policymakers were engaged to really decide, make a decision on what is really important, what will have a lasting impact. And that led to this particular drug and its formulation. And that led to implementation and is currently being adopted in so many African countries and other places. And I think this is a type of model that would be really good to use for long-acting injectables and long-acting therapeutics in general for women so that we can achieve a lasting impact. So I will stop there. Remember the priorities that are focused on infections, diabetes, postpartum hemorrhage. But there are so many other problems facing women, and long-acting therapeutics will definitely have a role to play in addressing many of them. So thanks a lot for your attention, and I want to thank my colleagues here in Liverpool next way. Thank you.
Thank you to all of our incredible speakers. And now I'd like to open the floor up for discussion, questions, ideas, any thoughts that have come up based on the presentations. In the front.
I'm coming to you with a mic. Thank you so much for those insightful presentations. My name is Dr. Emily Njuguna. I am a pediatrician based in Nairobi, Kenya, and I think I've learned quite a bit from the presentations here. I think my question is around representation in clinical trials. We know that, in as much as we're talking about pregnancy, having issues in terms of, just getting the right drugs, there's also the issue of representation when it comes to the cohort that we pick for some of these studies. We know that Africa's genetics is very diverse. And so I think for the panel here, I just want to understand, how do we ensure that we are also enrolling the communities for which, some of these drugs are really useful? Thanks. It's a hard one.
It's a very important question for all of us who are doing clinical trials. And I think the right answer is picking the right sites and involving the community upfront, not at the end of the clinical trial when it's already written, but while the trial is being developed, because that's the time where the community can say to us, this is something I'm interested in or I'm not, or there's no one here with that problem, why are you coming to our site? So I think the answer to your question is twofold. Number one, it means going to the right sites, not going to the sites that doesn't have a representative community that the question is appropriate for. And then second, going to the sites that you need, but also starting early to make sure that the people who are at that site are involved in trial development and want to participate so that the answer applies to them.
Thank you for an amazing discussion, and I've learned so much. My name is Mili Karina. I'm a nurse midwife and a board-certified lactation consultant from Kenya. My question is with regards to the long-acting therapeutics and whether you're keeping account of the changes in a mother's body, the physiology, and the changes in breastfeeding and the milk composition. How are you taking that into consideration with the research?
Yeah, maybe I can make a brief comments on that. So one of the things that have become very clear over time is the impact of those physiological changes on drug exposure. And that's why we see that drop in ripivirine exposure during pregnancy, both with the oral as well as with the long-acting injectable. So the key question is it clinically important? And that's where the question, so the changes might be there, but it might not be clinically relevant if the concentration still stays above the efficacy threshold. So what is generally done is to conduct study. That's why these studies are important in pregnant women. We can do some modeling to make a start and see what the expectations might look like. And then from that, we still need to do some studies. And usually these are done using opportunistic PK studies like the studies presented by Rachel. Women who were not intending to get pregnant, they were in a study, they get pregnant, and then we can conduct those studies in them. And that's also similar for lactation studies. But there are some purpose-designed studies. I'm sure Sharon might have a comment on this for ripivirine and cabotegravir during pregnancy, specifically enrolling pregnant women. And these women will be monitored during pregnancy, delivery, and postpartum. So all of these will provide the solid data that we need to really change the label and tell women whether it's good for them or not.
I think the other important point to discuss is that we need to develop even better models during pregnancy as well as postpartum. We have good models. They're certainly better than they were 5 years ago or 10 years ago. But the models that we're developing now really include much more information than our prior models. And those models, while they're still good, can't always replace actually doing the clinical trials. So the right answer is to do better models and using some of the newer drugs, not only long-acting drugs, but other drugs that haven't yet been studied in those models to come up with what we think is the right exposure, but also using some real-time populations So we can test the model and say, yes, this is correct, and this is the way to go. Per trimester, here's the dose we need, and here's the outcome.
All right, thank you. One more question. I wanted to find out what guidance exists for the frontline workers, midwives, how then they should educate the community with regards to long-acting therapeutics. Is there any guidance available for them?
I think for prevention, it's obviously going to be country specific in terms of what is both approved and available. And obviously accessibility and availability are two of the biggest hurdles I think we face. But in terms of prevention, the data look really fantastic for both cabotegravir and lenacapavir in terms of HIV PrEP. For treatment, the data we do have appear reassuring, but I think there's still more of a question mark than there is a thumbs up. And so what I tell my patients is that the data overall look great. If they're already on these drugs, I recommend continuing because that exposure will persist regardless. We can't take back the medication that's already in their system, but that at this time, in the absence of additional data, we are not prospectively starting women during pregnancy on the combination of cabotegravir or lenacapavir in the absence of truly extenuating circumstances because the data still aren't quite there. But that we really do hope that those data are forthcoming in the next year or two.
Great, thank you so much.
Just wanted to ask a follow-up question about the existing cabotegravir long-acting studies, both 2050 and CRAYON in the IMPACT network. How many are collecting breast milk PK?
I know that Impact 2050 will be collecting breast milk. Unfortunately, due to some funding shifts, we will be collecting and then soliciting funding in order to pay for the analysis. But those samples should be collected, so we should have that data, just maybe a slight lag between the PK data, the plasma PK data, and the breast milk data.
Yeah, so one could look to that when it emerges and just say this is what's known about the amount that is present in breast milk, and then one can look to the infant and neonatal data of kids, small infants receiving these therapeutics when that emerges as well, and say this is the safety and toxicity profile in that setting.
In terms of safety and toxicity for both cab and rilpivirine in breastfeeding, what we do know is that oral rilpivirine is quite safe, and there's no real concerns there. In terms of cab, we know nothing, frankly, but it is quite structurally similar to dolutegravir, and there have been no safety signals associated with dolutegravir in breast milk. So from that perspective, I would be quite reassuring about continuation of, or breastfeeding in people with either on or with exposure to cab and rilpivirine in the postpartum period.
And also, when you compare it to the counterfactual of switching to oral therapeutics and perhaps falling off of them in the chaos of the postpartum period, it would be more beneficial in terms of a potential effect at preventing transmission.
Or the alternative of not breastfeeding.
Yeah, but I think it would be really important just to remember that it's also a question of accessing the drug. And while it sounds silly, like, oh, you're taking long-acting, of course you'll stay on the long-acting, it's great. But if there's a shortage, or you can't get it, or you know that you're not going to get it 2 months from now, there may be many families, many women who opt actually to switch to daily DTG because they can get it, and they're not going to have a stock out. So I want to say, in some situations, it may be understandable why they would switch, or understandable why they wouldn't switch. And I want to say, because the universe of availability and access and cost is real, we can't sit here and say, oh, you should definitely stay on this or you should definitely stay on that. There's too many factors involved that right now we can't actually make those decisions.
Thank you very much. I'm Iradukunda Patrick. I'm from Rwanda Food and Drug Authority, and I enjoyed the talk early this morning. My question will start by appreciating the current technology Dr. Olagunju mentioned that include implantable long-acting, but I'm of making a follow-up question about whether there is what you are doing to ensure that the residues of the implant will not affect people with pregnant women who will be pregnant during those implantable injection. And the second one would be about what are you doing to ensure regulators are currently updated with what is going on research so that you will get a fast-track approval when those interventions are already proven. And the third one is about how the current shift in funding, as also Dr. Scott mentioned, it will not impact the progress being made in the research on long-acting, as most of the diseases that are being discussed today affect the community which is poor at some point. So the shift in funding could also impact the current progress that is being made in research. Thank you.
Yeah, if I can start with the implantable, but of course there are many questions that will be really important to find answers to. So I use the example of ethnogestural just to illustrate the potential value in that type of technology and the fact that there is actually a need for it when something needs to be removed. But whether that will be found to be efficacious and safe, that's one of those things that will need to be confirmed. But I think what will be important and will be of great value for women and children as well is to leverage technologies that have been found to be safe, so that all you need to worry about is now the drug. And if you're now combining a known drug, maybe used orally with well-established safety record, with a platform technology that has been used for other drugs, then it looks like the route to, or the pathway to approval might be really straightforward. So that could be the direction to look for that type of technology. And for regulators, what we're doing, that's why we have this community of practice, so that we can bring all the stakeholders together and have outputs and toolkits on the website that will really be of value to regulators. And when we have people like yourselves in the room, it's a nice way for us to then take those outputs and take it back to your agency, and also maybe collaborate with other agencies that are also in the community of practice and bring other people on board so that we can keep increasing the knowledge. And like you said, that will be really critical to making sure that when these technologies then get to their table, they know exactly what they're looking at and it to be quicker to review.
In terms of the funding shifts, I'm not sure I'm the best person to answer this. I'm currently in the thick of it. Sharon's welcome to comment. It is a really challenging funding environment in the United States currently for really any and all research, but especially HIV research and in minoritized and underserved populations. I think all of us are trying to pivot and find alternative sources of funding outside of federal funding. I think we all share this common goal and import of furthering long-acting and long-acting research, including in pregnancy, postpartum, and pediatrics. But I'm not going to lie that it's a real challenge right now.
And I think I'm just adding in my 2 cents. I think it's really important to also make sure our pharma partners understand that the default of, oh, do it in phase 4, or NIH will pay for it, or someone else will pay for it, is no longer an option. And then if we really want to serve our populations, we have to serve all of our populations, and we have to do it equally well. And that means we actually have to start early, involve pregnant, postpartum individuals in our studies, and say this is part of what has to be done, and not default to, oh, someone else is going to do it and pay for it. And as Rachel said, we are in a critical time looking at funding. We are working closely with our NIH colleagues to make sure that we still have a place at the table. And sometimes we have to fight for that place at the table, and we certainly are fighting for it. But everyone in the room is also helping fight for that place at the table. And we want to say thank you to everyone who's here, because you are part of the solution to making sure that pregnant individuals are included in research.
Good morning, and thank you very much for this interesting presentation. My name is Nathaniel from Ghana Food and Drugs Authority, a regulator. It's interesting that the topic, it's of course very clearly moved towards the PK and safety talk. But just to follow up on what Patrick said, if you look at most of these platforms, they are mostly sterile products. And for sterile products, the product is as equally important even before you start all your studies. I want to find out from Dr. Adeniyi, in terms of the innovation that you mentioned, is there a strong collaboration between your group and the industry in terms of who manufactures the product in question? Because you agree with me that for long-acting therapeutics, the excipients are very critical, and most of them, you need to move around how the release kinetics will not affect either your best approach or your dose dumping. So how do you intermarry that phase? Or it is done by University of Liverpool themselves? Because then that would be a very interesting twist to the formulation, design, and development itself. Thank you.
Yeah, thanks a lot. So just a quick, that's a very important question for ongoing development program in CELT. So the way we work is the preliminary work, for instance, the preclinical toxicity and efficacy studies, those may be done in preclinical models. So once we have confidence in the concept, the drugs that we currently have, as an example, they are drugs that are already approved. They're already in use orally, daily administered, and then we're trying to repurpose them for long-acting so that we can get a faster route to implementation and impact. So once we have sufficient proof of concept that we can transform this drug into long-acting, and then we prove that in animal studies. And then we take the technology and get a partner industry, a commercial manufacturer with sufficient infrastructure to actually take that technology and scale it up. So we follow that process. Same thing with the safety and toxicity study. We get a company, CDMO can do all of that study to regulatory standard. So everything is to the highest level that you can imagine. So they do all of that in preparation for first-in-human studies. So what goes into the first-in-human study is something that is coming from a GCMP, what do we call it now? Sorry, I'm not an industry person. You know, it's coming from the highest level of regulatory guidance and scrutiny.
Thank you very much. I'm Andrew Butler. I'm a clinical pharmacology assessor at the MHRA, so the UK regulatory body. Firstly, I wanted to sort of pick up on what Sharon was saying about this default exclusion of pregnant and lactating women from clinical trials and trying to move that from phase 4, and just highlight to anyone here who's not seen that there are current ICH guidelines under review. You can see those on the EMA website. The MHRA are publicising these. They're all open for public comment at the moment. So these are guidelines advising on how to include pregnant and lactating clinical trials. So I'd definitely recommend everyone have a look at those and comment if you can at all. And then second to that, I just wanted to ask, from the clinical data and the modelling that was shown by the presenters, it seems like the exposure of these drugs is dropping, but typically not affecting efficacy, although some questions on one of the drugs. Were those relating to total plasma concentrations, or is that free concentrations? Because it does seem like some of that drop would be offset by the free changes in free that occur during pregnancy as well. And I guess that links back to the physiological changes that discussed earlier as well. Thank you.
Thank you. That's an interesting question, and I think you nailed it. That sometimes we see that drop, but it's not necessarily the same with the unbound drug, which is really what is important. And that's something a lot of people have really emphasized over the years. But it's not so easy to do those studies and develop the bioanalytical method, so we still rely a lot on the total concentration. So what we see in that model is the total plasma concentration. But it's very reassuring, like you said.
Thank you. Thank you very much to the panelists. Thank you very much for a very interesting discussion this morning. My name is Dr. Shadia Nakalema. I'm an internal medicine physician from the Infectious Diseases Institute in Uganda. And I'm also a PhD scholar at the University of Liverpool, so I'm happy to be back to Liverpool. So I'm a part of Dolphin 3 Consortium, and we are essentially looking into creating evidence, or, generating evidence for the use of long-acting injectable ART treatments for breastfeeding and postpartum and pregnant women living with HIV. And in our consortium, we engage a lot with the community, and the conversation we had just recently informed us that pregnant women and breastfeeding women are very keen on being part of these kinds of studies, and they would also like to access these treatments because there's lots of advantages for them. And I'll tell you, it was kind of frustrating for me because in my current study, we can't enroll pregnant women and those that are in the immediate breastfeeding period, and women essentially wanted the drug during those periods. So I wanted to ask, I think maybe Sharon or Rachel, maybe when can we start? When can we start enrolling these women? I think Sharon, you indicated that it's important to study the drugs by trimester. I know that in the first trimester, for example, there is lots of safety concerns, teratogenicity and everything. Through the whole pregnancy period, there is concerns about making sure that the patients reach the therapeutic concentrations for the drugs. Rilpivirine is particularly of concern, maybe. But my question is, do we have a safe enough signal for rilpivirine and cabotegravir to study the drug at least during the third trimester? I would really be keen on knowing what you want. And then how do we move on? When do we start to include these women? Where should we start?
I'll say that for 2040 and now 2050, we are starting enrollment at 10 weeks. And the reason why is actually less because of concern about teratogenicity during organogenesis, but more that we felt that that was the happy medium of when we would see less spontaneous abortions in the first trimester. And we didn't want an unnecessary safety signal in terms of early SABs to interfere with our outcome data, given that our N was going to be relatively small. I think if you want to avoid organogenesis, obviously organogenesis is a process that's ongoing throughout pregnancy, but the most critical components are complete by 8 to 10 weeks gestation. I would generally, if you have concerns, I would recommend avoiding that period. But for CAB and rilpivirine, I think for rilpivirine, we really don't have concerns. And for CAB, there were no safety signals in HPTN 084. And frankly, again, in terms of animal models and given the structural similarity to dolutegravir, I really don't have concerns from what I've reviewed. So I think you could even start before pregnancy or upon diagnosis of pregnancy. The reason, again, we chose 10 weeks was to avoid those early SABs in terms of it causing a potential unnecessary safety signal.
I just want to add a one-liner comment in that oftentimes it's not up to those of us who are trying very hard, as you said, to enroll the patients on study, but rather there are third parties sitting at the table that often have a hard stop on when they want someone on study and who that person is. What are their comorbidities? Do they have chronic hepatitis B, etc.? So if you're asking the real world question of, can we just write prescriptions and give patients the drug? The answer is, that's not what we're trying to answer here. But if you're saying, I have a study, I've written it with colleagues and our pharma partners and a funder, the answer is not so simple. It's perhaps not up to us individually sitting in the room, say, when you could, but rather some kind of cooperative agreement between those who are helping fund the study, give the study drug, et cetera, as to when they want to. And that's what we're talking about today, is that we want to push our pharma colleagues into saying, stop saying no, but rather saying yes.
Thank you so much. I think we can probably end with that.